the mentors.
So we have started, yeah.
Shall we start?
Yes.
Few seconds, I mean a minute or two.
Okay,
People are
okay.
joining, I think.
Okay.
Shall we start now? Sir, can start, I think so.
Yeah. Shall we start now?
Yes, sir. Go ahead, sir.
Okay. Welcome to all the neuroscientists of KNA. We are having the third webinar, which we started this year. Today's program will be conducted by neurologists and neurosurgeons from Mangalore. I request Dr. Satish to take over and moderate the program and conduct the program.
Yeah, hi. Good evening to everyone. On behalf of Karnataka Neuroscience Academy, I welcome all the panelists, all the speakers, and the delegates to this pleasant evening. This is the third web series from the webinars, and this time it is from Team Mangalore. So instead of 3 cases, I think there is only 2 cases. The first case is going to be a little more interesting, I believe. Okay, so to make it more interesting, we have got a case of unusual presentation of Langerhans cell histiocytosis. So I hand over to the team Mangalore.
Recording in progress.
To start the case. So this will be by one. Hello.
Hello.
Hello. Can I ask the presenter to present the case, please?
Yes, sir. Yes, sir. I'll proceed, sir.
Hello. Am I audible? Hello.
Yes, sir.
Yes,
We are audible. You are
Yes,
audible.
we are
Sir, can
audible.
hear. So, sir, I'm Dr. Aghavendra from Father Mullas Medical College, and this is my DM postgraduate, Dr. Vinusha. She'll be presenting this case, sir. Vinusha, can you go ahead, ma? We'll
Yes,
present.
sir. Yes, sir. My screen is visible, sir.
No.
Now you need to share the screen, Navinisha.
Now is it visible?
Yes.
Yeah.
Yes.
Yeah,
Yes.
yeah,
Yes.
yeah.
Go ahead.
I'll be proceeding with.
Vinusha, go ahead. It's a scene. It's nicely visible. Yeah.
Yes, sir. The slides are not moving. 1 minute, sir. I'll just. Good evening, everyone. I'll be discussing about a 46-year-old lady. She's a housewife, still +2, Malayalam-speaking person hailing from Kannur. She's a right-handed individual. Am I audible, sir?
Yes.
Audible,
Yeah,
but
yeah,
slides
yeah.
is not moving. Slides, yeah.
Yeah, okay. Presented with the chief complaints of imbalance while walking since 5 years, with tremulousness of both upper limbs since 5 years, with sliding of speed since 4.5 years, with skin lesions over scalp and periorbital area, followed by visual loss since 2 years.
Finish your slides. Slides are not moving.
Yes, sir.
Slides are not moving.
It's moving now, sir.
No.
It's only we're in the first slide. Rare case of adult onset LCH. Your
Dr.
chief complaints
Vinusha,
are
you must, I guess, go back to the presentation and then
Yeah.
play the video
See,
from
now
the.
it is
Yeah.
moving.
Yes.
Yeah.
Yes.
Okay, fine. A 46-year-old female, she's a housewife, studied till +2, Malayalam-speaking person, hailing from Kannur. She's a right-handed individual, presented with the chief complaints of imbalance while walking since 5 years, with tremulousness of both upper limbs since 5 years, with slurring of speech since 4.5 years, skin lesions over scalp and periorbital area, followed by visual loss since 2 years. Coming into history of present illness, she noticed that imbalance while walking, which is insidious in onset, swaying to either side without any directional preponderance. And this increased imbalance has been noted while passing through the narrow passages or in a crowded places. And family members has noticed that she would walk like someone who is under the influence of alcohol. And there is no history of difficulty in sitting onto the edge of bed, and there is no marked worsening reported on eye closure or in the dark, and no history of any postal dizziness or sense of motion of self or environment, with no hearing loss or tinnitus. And there is no weakness noticed in legs or arms or any abnormal sensations or over any part of the body. And she could feel cold and hot water sensation while bathing. And while bathing barefoot, she is able to walk without any altered perception of grounds. After 10 to 20 days into illness, she noticed tremulousness of both hands, and she noticed that tremulousness would increase on doing target oriented tasks, and there is difficulty in reaching for objects. And she also noticed that there's difficulty in guiding her foot into the footwear, but after wearing it, it wouldn't slip from the feet. And this there is change in handwriting with increased tremulousness while writing. 6 months into the illness, husband has noticed that there is slurring of speech, that she would speak slowly and she would break the words with unpredictable pauses, with no straining of syllables or explosion of sounds, making it difficult for the family members to understand. However, she could understand the family members' conversation and she could make a meaningful talk. And there is no history of any difficulty in swallowing food or drinking water, with no history of any repeated choking episodes and no nasal twang. 2 years into illness, she developed multiple swellings over the scalp, which were painless with no history of any discharge or ulceration, with spontaneous resolution, and they developed at other areas of scalp. And she noticed that there is a painless swelling around the periorbital on the inferior margin, which gradually increases in size with no ulceration or discharge. Along with the periorbital swelling, she also noticed that there is insidious onset of blurring of vision in both eyes, which is progressive and painless. Now she couldn't read and write, and she could just identify the persons, but could see the face of the persons very blurred, and she could just identify the color. Initially, she would enjoy the TV serials, but now she's not able to enjoy it. She just have to enjoy the discussion of the TV serials, and she couldn't see the name of the person calling on her phone. But she's able to tell if it's morning or night, and able to appreciate light in the dark. Because of the visual affection and imbalance while walking, she needs family person support or furniture at home for walking, but she's able to do her daily to do activities independently. So since last 1 month, she has infestation with the head lice with mild pain on touching the lesions. There is no history of any alteration in the behavior with no any personality change hallucinations. There is no history suggestive of any cranial nerve involvement. There is no history of any weakness in the limbs with no other involuntary movements other than tremulousness is noted. No history suggestive of any truncal weakness, neck weakness, or respiratory involvement, with no history suggestive of any autonomic symptoms. And there is no history of any high risk behavior, repeated infections, headache, fever, weight loss, or any constitutional symptoms, and no history of any drug exposure or toxins inside. And there is no bowel and bladder involvement. So coming to past history, no significant past illness was present. She took treatment for primary infertility, and she conceived after 16 years of marital life. And she's born a non-consanguineous marriage, and there is no history of any neurological illness. Still 2 generations of family on maternal or paternal side. Personal history is normal. To summarize my case, she's a 46-year-old lady presented with imbalance while walking, with tremulousness of hands and slurring of speech, with skin lesions and visual affection. So it's an insidious in onset, gradually progressive, symmetric cerebellar syndrome with visual affection and skin lesions with negative family history, with no cognitive impairment, vision affected, second cranial nerve involvement, and with no involvement of other cranial nerves, without any extrapyramidal, pyramidal, bowel, bladder, or autonomic involvement, or any other constitutional limits. I localize it to cerebellum. Can I proceed, sir?
Yes, please. Yes, please.
Coming to physical exam.
Why do you say cerebellum?
Sir, there is imbalance while walking, and there is tremulousness of hands, and it is mostly gait ataxia. I could see. That's why I have localized it to cerebellum.
It could be spinocerebellum, no? Why
is
are
no-
you telling it is cerebellar involvement? It could be just connections involvement. What is
Yeah,
the
cerebellum and its
strong thing in
associated-
your history saying that
Yes.
it is cerebellar involvement? You yourself have told that.
Yes, sir.
What is that?
It could be cerebellum and association, sir. There is
No, the speech involvement says that it is cerebellar involvement.
yes, sir.
Understood? Speech involvement.
Yes,
If
sir.
otherwise this tremulousness, imbalance and all could be because of the cerebellar
Correct.
connections.
Yes, sir.
If
Yes.
saying that the speech involvement points out to the
Dissert.
involvement of cerebellum.
Yes,
Okay.
sir.
Yes. Correct, sir. Thank you. Actually, Vinusha, the sir said
Yeah.
presence of this ataxia and
Ataxia
imbalance
and
could be
ataxia.
cerebellum and or its connections. The
Yes.
moment dysarthria comes, as sir said, it will go to directly to the cerebellum rather than its connections.
Okay,
Mm.
sir.
What is the cause of visual impairment?
That we don't know, sir. She came with visual impairment, sir.
Where
Could be
is
part of the
local-
illness.
It
Localization
could
is
be
which.
associated with illness, or there is no case report still now in that Langerhans.
No, not like that. Not like that. We are in
Okay.
history.
Yes, sir.
History. Cerebellum, it's confirmed with the dysarthria.
Yes, sir.
Now,
Yes,
sir is asking.
like vision
part of
affection. Yes, sir.
Vision is instead of putting a new disease, we're trying to explain the same disease with a single etiology. We're not come to examination or histopathology, but what possibility, which cranial is affected along with the cerebellum? What could be the possibility, sir is asking?
So it could many spinocerebellar ataxias, which optic atrophy could be presenting like that.
Okay.
So you want to consider degenerative causes.
Yes, sir. Yes, sir.
So what are your
But,
differential diagnosis at the end of the history?
So I'll be proceeding with cerebellar ataxias like spinocerebellar ataxias and idiopathic late onset ataxias, Fragile X syndrome, tremor ataxia syndrome, sir.
Why not MSA?
There is no autonomic involvement, or there is no history suggestive of any Parkinson symptoms, sir. It's only cerebellar, and there is no history of any bradykinesia or any other system involvement right now.
This overall, it looks like a cerebellar plus syndrome because we cannot ignore the symptom of visual because
Yes,
this
sir.
patient is having 2 years history of visual impairment.
Yes,
So
sir.
this is definitely a cerebellar plus syndrome. We have to consider differential diagnosis of cerebellar plus involvement of vision.
Okay, sir.
No, just Dr. Vinusha, one question to why you are not thinking of space occupying lesion involving the cerebellum and its secondary effects?
There is no history of any headache or seizures, or no history of any constitutional symptoms, sir. It could be, sir.
What is a simple cause which can
Yeah, you
produce
see,
cerebellar
cerebellar
involvement
lesions,
and
they need
visual
not have to
impairment?
present with any
Like it's a
constitutional
CP angle
symptoms,
tumor which can produce
Hearing
pressure
is
effect and
generally-
can produce optic atrophy on a long run. But it
Uh,
would have a asymmetrical
Hello?
involvement. This patient has got
Correct.
symmetrical involvement.
Yes, sir.
True, sir. True. Having a CP angle tumor going on for years together like this, without having any ear symptoms like tinnitus or loss of hearing. Plus, as sir said, they used to usually have asymmetrical symptoms, but it was a bilateral symmetrical tremulousness, both hand, speech came all together. So difficult to explain with Ixol alone, that is cerebral, CP angle tumor alone, quite difficult. But as because raised ICP feature, headache also was not there, vomitings were not there. Probably we really thought of unlikely for space occupying lesion, though it is one of the differential. But for going on beyond 2 years, with bilateral symmetricality. That point little was against space occupying lesions, sir, here.
Shall I proceed, sir?
Yeah, please proceed.
Coming to physical examination, she's a very conscious and cooperative person. Vitals were stable with no postural drop of BP. On examination, there is a pallor, cervical lymphadenopathy, which is 1 × 1 centimeter, soft to mobile, non-tender, no matting has been involved, and raised firm swelling present on the inferior margin of periorbital region. There are multiple crusted plaques with the nits over the scalp, which are yellowish to skin-colored papules and plaques with pus points and minor ulcerations noted over the scalp. These are the xanthelasmas we have seen, sir, and these are the skin scalp lesions we have been seeing. So coming to higher mental functions, there is scanning type of dysarthria. Rest of all the higher mental functions were normal. And in cranial nerves, pupils were symmetric with reaction to light, and there is decreased visual acuity with light perception present, able to count fingers till 4 meters. She is able to recognize faces. On fundus, there is optic disc pallor and optic atrophy. And rest all the cranial nerve examinations were normal. In Moda's examination, there is brisk reflexes with bilateral Babinski, and spread of reflexes was present, with the sensory examination being normal. In cerebellar examinations, on coordination test, there is ataxia, past pointing, and intention tremors. There is dystadicokinesia with tandem impaired. She's gait, she's able to get up from sitting position with the assistance. With a wide-based gait with variable step length, and imbalance is more pronounced during turning in the assisted gait. So there are no other signs of meningeal irritation. There is scoliosis noted. Other system examination is normal. To summarize, she's a 46-year-old born to non-consanguineous marriage with negative family history, presented with chronic progressive symmetric gait ataxia, tremors, scanning type of dysarthria, with visual affection and periocular xanthelasmas and scalp lesions. So my neurological deficits were scanning type of dysarthria with gait ataxia, decreased visual acuity, optic disc pallor and atrophy with bilateral deep tendon reflexes, and bilateral extensor plantar with cerebellar signs. So I localize it to pan cerebellum with pyramidal tracts and second cranial nerve affection. My pathological diagnosis mostly is degenerative, or it could be sporadic, it could be malignancy, or it could be paraneoplastic, with the etiological diagnosis of histiocytosis, Athene Chester, cerebroteninous xanthomatosis, and neurosarcoidosis. Shall I go on, sir?
No, that's good, but you see, you are keeping the pathological diagnosis as the etiological diagnosis, no? So what are the reasons to think in terms of histiocytosis or ECPCs and cerebroteninous xanthomatosis?
That xanthogranulomas we have seen, no, sir. Just we thought whether it could be cerebroteninous xanthomatosis. And cerebellar presentation in the skull lesions, we could the bone lesions, we thought it could be histiocytosis. We thought it was initially malignancy, sir. After that, we thought it could be histiocytosis.
No, histiocytosis is it's a definitely pathological diagnosis.
Okay.
On clinical examination, will not be able to come to this diagnosis.
Your voice is breaking, sir. I couldn't hear actually.
Yeah, please proceed.
Yeah.
Proceed. Please go ahead.
Sir, here, sir, though histiocytosis is more of a histopathological diagnosis, in view of scalp lesions and xanthelasma lesions, we thought of, we also were included a skin dermatologist also during our thing. So we kept a diagnosis of histiocytosis as a disease name per se, not like it's a pathological diagnosis of a histopathology, but we thought of histiocytosis, Langerhans or non-Langerhans, or like sarcoidosis, tuberculosis. We thought of histiocytosis even without a biopsy, even before a biopsy. We had a doubt because of the scalp lesions, sir, along with the scalp lesions, trying to explain everything in a single etiology, neurological and skin and scalp all put together. We thought of, we had a kept DD from the beginning only as a histiocytosis, maybe Langerhans, maybe non-Langerhans, xanthogranulomatous disease, but though it is ultimately confirmed by histopathology, clinically also we thought of histiocytosis as a disease per se, histiocytosis as a disease per se, sir.
Okay, thank you.
Yes.
So on exam,
And
Yes,
Vinusha, cerebrotenant xanthomatosis, though can have xanthoma anywhere,
yeah,
but they'll have a classical xanthoma in the
yes,
at the Achilles. So
Achilles
that is a
tendon.
classical almost presence of xanthoma in the Achilles tendon, which was not there in our patient. So present that is point little against CTX. But nevertheless, one of the DD has to be kept. And as Shivanand Pai sir already mentioned, cerebral plus syndrome still be kept here. Though skull lesions are difficult to explain, MSAC, OPCA is one of the important different diagnoses because you got pyramidal signs also now. Though you didn't have a typical autonomic features, pyramidal, extrapyramidal, and cerebellum, though one plus or minus, you can still keep cerebellar symptoms. But tendon xanthoma is little unlikely because there is no xanthoma is Achilles tendon here.
Paraneoplastic and malignancy related still to be considered because there is a lot of skin lesions,
Correct.
pyramidal, cerebellar, optic nerve involvement, which all can be explained related to malignancy and paraneoplastic.
Correct.
Okay, sir. Proceeding with the investigations, had normal investigations, everything was within normal limits, sir. With other special investigations we have sent, autoimmune panel and paraneoplastic animal was negative with vitamin B12 levels being normal. Her CD test is normal. Ultrasound abdomen pelvis is also normal. And the skin biopsy of the xanthal is consistent with the xanthogranuloma. And serum ACE levels were also normal. So these are the MRI findings with flare showing cerebellar atrophy. And we can see the osteolytic bone, osteolytic lesions involving the left parietal bone with enhancement seen in the extracalvarial soft tissue. These are the CT cerebrum cuts in the bone windows, which are showing the extracalvarial soft tissue with osteolytic lesions of the left parietal bone. And the screening of the MRI has shown that there is scoliosis noted with the L2 vertebral fractures was seen. So we send the patient for the biopsy, sir, the scalp lesions. In that scalp lesions, we have seen that in proliferative phase with extensive infiltration of Langerhans cells proceeding into epidermis and below it. And there is a granulomatous reaction with the extensive sheets of histiocytes with scattered foam cells and the multinucleated Taunton and Jane cells. And the immunohistochemistry is very important to differentiate between Langerhans and non-Langerhans, and it is consistent with S100 positivity and CD18 positivity. So this is the biopsy we have, which is consistent with the Langerhans cell histiocytosis with associated xanthogranulomatous features. So after that, she's being now treated as a Langerhans cell histiocytosis with xanthogranulomatous feature with neurodegeneration. She received 4 cycles of chemotherapy with fludarabine, and each cycle lasting for 5 days. And repeat PET scan was done, which is showing favorable response. And she is now currently on 6 mercaptopurine maintenance therapy. And there is resolution of calvarial lesions and with 50% improvement in the gait ataxia with a persistent scanning type of dysarthria and visual loss. So these are the post-chemotherapy lesions with the resolution of the calvarial lesions we see. So this is a post-chemotherapy PET scan, which showed that there is only residual disease with no clinically significant abnormal metabolism elsewhere noted. So these are the PET scan findings we could see. Okay, sir.
Yeah.
Shall I go to discussion of Langerhans?
Yeah, please.
Yeah.
Yes. So this Langerhans histiocyte is a clonal expansion of myriad precursors that differentiate into CD1A and CD207 positivity. It is most commonly seen in pediatric age groups and which is very rare in the adult age group with an estimated prevalence of 1 to 2 cases per million. So traditionally, it has been classified into 3 types. It is eosinophilic granuloma, lettered sieve disease, Hans color, and Christian disease. This eosinophilic granuloma, there are single or multiple bone lesions without any visceral involvement. In lettered sieve disease, there is a granulomas involving visceral organs like liver, spleen, lymph nodes, CNS, and bone marrow and bones. And Hans color Christian disease, it's a triad of multiple osteolytic bone lesions with exophthalmos and diabetes insipidus. There is clinical classification depending upon how many organ systems is involved, and in one organ system, number of organs has been involved. It is multi-system if it is more than 2 or more systems has been involved, and it is single system if it is only one system has been involved. In CNS LCH, it presents as humorous lesion and neurodegenerative lesions, and in neurodegenerative lesions, it could be imaging findings or it could be presenting with CNS symptoms. In Langerhans cell histiocytosis, most common involvement of organ is first is bones here, next is skin. Generally in pediatric age group, we generally see. CNS presentation is generally very rare. It is generally around 15% of percentage is seen. They can present with cerebellar involvement or it can present with basal ganglia involvement with seizures. So there is a non-Langerhans histiocytosis. Depending upon it is divided into class 2A and class 2B histiocytosis. Class 2A, it is dermatofibroma, zonal xanthogranulomas, xanthoma disseminatum, erythema disease, progressive nodular histiocytosis. Class 2B, there is hereditary and acquired. Hereditary, it is familial hemophagocytic lymphohistiocytosis, familial sea blue histiocytosis, hereditary progressive mucinous histiocytosis. Acquired, it is diffuse plain xanthomatosis, reticulocytosis, Rosai-Dorfman's disease, necrobiotic xanthogranuloma. It is very important for us to differentiate between Langerhans and non-Langerhans. Langerhans most commonly seen in children and juvenile age group, and the bone marrow derived antigen present. It is expansion of bone marrow derived antigen presenting cells, whereas the non-Langerhans, it is monocyte macrophage lineage. And in immunohistochemistry, there is CD1A positivity with S100 positivity, which is negative in non-Langerhans cell histiocytosis. So this is a case report which was published recently in 2023 here in Wuhan. With this patient is also presented with she presented with more of neuroendocrine manifestation, but they started on chemotherapy, but she died of severe pneumonia. This is the only case report I could find in the literature, sir. And this is one of the Eltham-Chester case report, which includes under non-Langerhans cell histiocytosis. With the treatment of steroids, the bone lesions has been resolved with no other relapse has been seen. So take-home messages: LCH may be underdiagnosed in adults. CNS presentation with bony lesions, we have to think of other granulomatous presentations like LCH apart from normally TB and neurosarcoidosis. It is important to differentiate LCH from non-LCH. In most of the cases, it may be coexisting, but they have to be differentiated because they differ in treatment protocol and prognosis. Early identification and confirmation of diagnosis is important for initiation of treatment and prognostication. Thank you.
Vinisha, that was a very lovely presentation maintained by Dr. Raghavendra sir.
Yes,
Now
sir.
I think we have got some time for discussion, so I request the members to join in the discussion. Raghavendra sir, you would like to highlight something about, a little more about this disease?
Sir, when I was a postgraduate, Dr. Ravindra speaking here. When I was a postgraduate, I had a similar case, which it turned out to be a non-Langerhans. I think Vinisha showed in the last slide just before said that's called Erdheim-Chester disease. I was a DM postgraduate along with my professor Rajendra Singh Jain. This case was interesting, sir. It was a case of a non-Langerhans cell histiocytosis, which was Erdheim-Chester disease, which was HAM positive and CD1 was negative. And this patient had calvarial lesions. Usually, whether Langerhans or non-Langerhans histiocytosis, they usually causes osteosclerotic lesions. But in my patient in Jaipur, as well as our case that Vinisha presented, this patient had a mode of osteolytic lesions. And usually, if at all bone is involved, it is a long bones which are involved. Calvarial bones are not commonly involved, which was there in this patient as well as my Jaipur patient. And my patient responded to steroid like anything, and he was not given any other medications, and he had a lesions in the brain also, parenchyma. He was in frontal lobe, temporal lobe, parietal lobe. If you go through the article, British Medical Journal, I have given all the 4 MRIs, 1, 2, 3, 4th. Now the last MRI which was done was completely resolution, only scar is remaining, for which is taking carbamazepine for the seizures, which is well controlled. They never had a relapse. He never had a relapse and never gave anything else. And they showed a great response to a steroid. We didn't put any other immunomodulator steroid sparing. Probably non-Langerhans cell or Erdheim-Chester is more easy to treat compared to Langerhans cell histiocytosis, which is quite aggressive like in our patient. But interestingly, sir, our Langerhans cell showed a dramatic response to to therapy, we can see scalp lesions almost disappeared. Hairs have come back. Unfortunately, initially she was shown to multiple dermatologists and all. And since when the patient developed cerebellar features and all, probably it was thought as a part of a single disease. So we have always a norms, thinking that, whenever skin lesions are there, ulcerative lesions are there, when, skin biopsy shows granuloma, we think of tuberculosis, sarcoidosis. Come on, most common is, yes, but we should not forget histiocytosis, xanthogranuloma. Rather, it was reported as xanthogranuloma. Then we took a second opinion, and really want to thank whole Niman's histopathology team, Dr. Yash, Dr. Nandish, everybody in Ria ma'am, all took it in a very high spirit, and they could give us nice slides, and they were very clear to tell us that this is Langerhans histiocytosis, and probably then we could get a proper say diagnosis. So when I was in Jaipur, I also seen another case of xanthogranuloma, but it was a cerebrotendinous xanthomatosis. Patient had a severe cerebellar features with a xanthoma in the tendon. So what I want to mention that whether it is xanthogranuloma CTX, or whether it is LCH, or whether it is Erdheim-Chester, all have an affection for cerebellum and cerebellum, bones and bones. But sometimes coming with a calvarial involvement, skull bone involvement, osteolytic lesions. Now probably we should think, these are no more rares now. Rare things are rare until we think of. So now these have become common thing and potentially curable, treatable. My Erdheim-Chester is still walking without any system. Now also I call him, he says, I'm totally fine. Now this LCH lady is already doing well, and we could see her PET scan. She just got discharged few months back and already showing a good response. And we will probably she will do further well, much better with the other therapies going on now. So what I want to mention that LCH, non-LCH, very important to differentiate, and probably they response very good for treatment. And kindly we need to do special staining. We should take a help of neuropathology like Nimans and all, so that we don't have to miss even immunist, special staining if it is required. Because in Jaipur I could not do special staining. I could only get CD1 and ham 56, and with that only we could diagnose. But probably now Nimans have done extensive study in our case, and they could categorically say this is LCH, because both LCH and non-LCH can coexist together. That's the reason. So gone are those days giving empirical ATT or sarcoidosis treatment alone. So we must have to think beyond the thing. Probably it will be very helpful. And osteolytic lesion is one of our rare things, and optic nerve also here.
Thank you, Dr. Ravindra. And now,
thank you, sir. Thank you.
Dr. Vinesh also. Hello.
Yes, sir.
Now I request Dr. Shefali to present her interesting and rare case of stroke. She will be mentored by Dr. Shivanand Pai. I'm also quite eager to know what is the interesting case of this stroke. Dr. Shefali, please.
Yes.
Thanks, sir. Thank you so much. Thank you.
Yeah, thank you.
This was a very rare case of stroke. We have seen different rare cases which have come to our institute. Like patient has taken cannabis, cocaine, nasal drops, your xylometazoline, producing rebound hypertension and producing stroke. But this patient was a very interesting case. Shefali will tell more about that. We'll discuss at the end.
So you are still maintaining the curiosity.
Yeah.
I thought that you were revealing it, rather still you are making it more exciting. Dr. Shefali, please come soon.
Yes, sir, sure. So, good evening, one and all. I'll be presenting an interesting and rare case of stroke. So, we had a 64-year-old male, agriculturist from Puttur, who got admitted to our hospital on 2nd February 2023. So, he came with chief complaints of multiple bee stings all over his body on 1st February 2023. So coming to the history of presenting illness, he was in his usual state of health until the morning of the 1st Feb, when while walking in his backyard at around 10 a.m. in the morning, he was stung by multiple bees, that was around 200 bees, all over his body, following which he was taken to a local hospital where he was managed with steroids and antihistamines. So post getting treated with steroids and antihistamines, he had multiple episodes of vomiting, followed by difficulty in swallowing. That was for both solids and liquids. And we also noticed that he was unable to sit up without support, lift his head up, and had difficulty in keeping his eyes open. So Following this complaint, they referred this patient to us for further evaluation on the next day. Past history is known case of type 2 diabetes mellitus, no other comorbidities. So on arrival to the emergency department, he was drowsy, arousable to call, he was tachypneic, bilateral pupils were equal and reactive. We noticed that he had bilateral ptosis. Extraocular movements were full. He was moving all four limbs. We noticed that he had proximal motor weakness compared to the distal, both upper limb and lower limb, symmetrical, neck flexor and extensor weakness. So reflexes were present and bilateral plantars were extensor. Sensory system could not be assessed, cerebellar system could not be assessed, and gait could not be assessed. So he was admitted in the MICU and he was found to have tachypnea with worsening sensorium, for which he was intubated and connected to the ventilator on the same day. So coming to the routine labs that we did, HP was 11, total count was 14,320. It was neutrophil predominant. Platelets were 1,34,000. CPK was raised, it was 2,468. Whole blood clotting time was done, which was more than 20 minutes. PTINR were within normal limits. APTT was 24. Direct Cummings test was done, which was negative, and
Dr. Shefali, we lost
Shefali, you are not
your
audible.
audio.
You have muted your audio, I believe. Yeah.
Can you hear me, sir?
Yeah.
Yeah, now please go.
Yeah. So he was started on IV antibiotics, that is cephalosporin sulbactam, hydrocortisone, neostigmine, nebulization with aspirin and budesonide, and hematologist opinion was sought in view of that whole blood clotting time being more than 20, and he was transfused with 4 units of FFPs. Post this, he was taken up for an MRI, which showed a huge right cerebellar infarct with hemorrhagic transformation. So looking at this MRI, we took a neurosurgery opinion and was taken up for emergency midline posterior fossa decompressive craniectomy with evacuation of the right-sided cerebellar hematoma was done. So post this, he was shifted to the neurosurgery ICU. Antibiotics were added with metronidazole and amikacin. He was started on anti-edema measures and anti-epileptics. So a repeat CT brain was done on post-op day 4, which showed decrease in the hemorrhagic transformation. So in view of prolonged intubation, he underwent tracheostomy on the 10th of February and was shifted to wards in a stable condition. So daily labs are done, which showed improvement in the CPK levels, IgE levels, in the total count and the HP. Other values are within normal limits. And throughout the stay, his blood pressure was around 140 to 150 without any hypotension or any hypertension. On 20th February 2023, he started developing fever spikes every day and had tachypnea, for which he was shifted back to the ICU. So ET secretions were sent, which grew Acinetobacter, which was found to be pan-resistant. Urine cultures were sent, which grew Klebsiella, which was again pan-resistant. So his antibiotics were hiked up to polymyxin B along with the amikacin. So, however, on 24th of Feb, he had bradycardia and cardiac arrest. We had initiated resuscitation according to ACLS protocol, but however, we could not revive him in view of sepsis and septic shock, and he was declared dead at around 8:30 a.m. So, coming to review of literature on this case, we noted that.
You can discuss.
Yes.
No, Dr. Shefali, sorry for the interruption.
Yes, sir.
I have got few queries. You see, when the patient has come brought to the ER room, that's the emergency room.
Yes.
So what made them to refer it to the neurologist?
They referred to us telling that there was neuromuscular junction weakness because he presented with the dysphagia along with proximal myopathy features, proximal more than distal, upper limb and lower limb symmetrical weakness. This is what he was shifted to us with.
In fact, he was referred to us with this bilateral ptosis, breathing difficulty, and proximal weakness, saying that there is an involvement of neuromuscular junction, and he responded well to neostigmine. In fact, we were thinking of more of a neuromuscular junction involvement secondary to the bee sting. We were not thinking of a stroke at that particular point of time. Since his tachypnea worsened, our intensivist intubated the patient and sedated since he was fighting on ventilator. So later, since he was in persistent altered sensorium, imaging done, and we could diagnose a stroke.
But how to
Was
explain
there
the
any
neurological
suspicion
findings with that, sir? How to
prior
ex-
to the imaging in the
Literature says that patients do have neuromuscular junction involvement with the multiple bee stings. It can affect the neuromuscular junction and can produce transient weakness. And since this patient had multiple bee stings, almost 200 bee stings, and it was not removed in the local hospital, only they had given hydrocortisone and antihistamine. That's the reason probably the envenomation must have happened, and then he must, the load of the toxin was very high in the body.
Sir, but how to explain the
No,
neurological
this is
findings
quite
with the
acceptable.
cerebellar lesions?
Later, since the patient was in altered sensorium, we did an imaging, sir, which showed a large cerebellar infarct and mass effect was there, which is responsible for his altered sensorium.
No. Doctor, there was definitely a cerebellar infarct, no doubt about it, but there was no significant mass effect in the form of hydrocephalus or anything of that kind. You see, only the fourth ventricle was effaced. So definitely the sequences what we have seen is not showing any hydrocephalus.
Sorry to interrupt. I was wanting to ask Dr. Shivanan whether there is any question of coagulation issues causing bleed.
Whole blood clotting time was prolonged, but thing
Okay.
is the MRI definitely showed a diffusion restriction, and infarct was also there. It was not only the hemorrhage.
Correct.
No. How do you explain a localized infarct?
Sir, we will discuss that, sir, in the literature, review of literature, we'll discuss that, sir.
So, no. So basically, what cerebellar hemorrhagic infarct was an incidental finding, which was never thought of clinically.
Clinically, but this patient had imbalance. He was not able to sit. All those things were there, but he had other things like tachypnea and all. We couldn't assess the cerebellar signs properly at that particular point of time.
But there was an overlap of neuromuscular weakness with the stroke, and because there was a sedation given, probably good that MR was done quickly, and it was not delayed.
That's what I'm telling you. So what led you to investigate towards MRI was that's the important thing. It is when we are
because patient was fighting with the ventilator, he was sedated. When we tried reducing the sedation, he was not responding. So that is the reason we got an imaging done.
Okay, that's fine. And you want to really reveal the cause for this hemorrhage in the discussion. It's the review of the literature. So we wait for it.
Yes.
Shepard, please proceed.
So basically, B venom contains certain neurochemicals like apamine, melatonin, and mast cell degranulating peptides. It also contains proteins, peptides, amino acids, and phospholipids, and more than 80% of it is water. But however, these chemicals, that is melatonin, is classified as a lytic peptide that is able to destroy the membrane phospholipids, which includes erythrocytes, leading to hemolysis. So also we have phospholipase A2, which is the second most abundant compound, and the most allergenic and immunogenic protein, which also acts as a hemolytic factor. So we also have apamine. This apamine selectively inhibits calcium-dependent potassium channels found in the central nervous system, which causes increased firing of neurons in the mesencephalon and the cerebellum particularly. So apamine is also able to activate inhibitory muscarinic receptors of the motor nerve terminals and thereby reducing neuromuscular transmission. So this can both cause hemolysis along with neuromuscular junction, decreased transmission in the neuromuscular junction. So we have rare clinical manifestations of bee sting, that is encephalitis, stroke, neuromuscular paralysis, acute inflammatory polyradiculopathy, and optic neuropathy. So we have certain case reports. There are very few case reports. One case reports in Annals of Indian Academy of Neurology showed an acute ischemic stroke due to multiple bee sting. It was a delayed complication noted here. It was a case of a 41-year-old man who had a fatal right MCA territory stroke following an attack by over 50 bees. And most of these attacks were on the face. And they noticed that the patient succumbed to this infarct also. There's another journal that is Translational Neuroscience. They have reported a cerebral infarction following multiple bee stings, where they noticed that patient had lateral medullary infarct, and on progressive days, they noticed that the infarct size had worsened, and this patient also succumbed to the bee sting. There was another case report which was done by Osman Temizo. It was published in a neurologist journal, that was stroke due to a bee sting, where they had 2 hours later, by multiple bee stings, it was confirmed that he had cerebral infarctions. And there was another journal where on JAPI, where they noticed that a 25-year-old male who developed left-sided monoparesis and transient visual loss following multiple bee stings. And there was involvement of both anterior circulation and posterior circulation in this case. So basically, we have very few limited handful of case reports with bee stings. However, it is seen and it may occur post-acute phase within 4 to 10 hours. And most of the reported cases are due to multiple bee stings, and most of which are around the face and the head region. So the exact etiology of stroke following bee sting has not been elucidated till now, but the proposed mechanisms are due to hypotension and reduced cerebral perfusion due to anaphylaxis. Second is the hypocoagulable state and platelet aggregation due to thromboxane A2 and phospholipase activation, and also vasoconstriction due to retrograde stimulation of the superior cervical ganglion and the carotid spasm. So these are the 3 proposed mechanisms, however, in bee sting.
Dr. Chappal, just I would like to ask whether these infarctions are limited to the CNS only, or it can happen involving other systems like renal system, cardiac system, pulmonary infarction.
Yes.
Because this should be a generalized phenomenon, no?
Yes, sir. It can cause, bee sting has also noted to cause empyema, sepsis, cardiac toxicity in separate. It may not be multi-system, it can separately cause different entities.
Our patient had persistently very high IgE level.
Infarctions. No, sir. I'm specifically speaking about the infarctions. It's so what we are concentrating here is only the CNS related infarctions, no? But
yes,
these infarctions with the same pathophysiology can happen with other systems also.
Were absolutely normal, sir. LFT, RFT, there was no other, chest X-ray was fine, Kudico was normal. There was no other evidence of infarcts anywhere else in the body other than the cerebellum. However, later he developed sepsis.
No, Dr. Chappal, you are not audible for us.
Sir, am I audible now? Am I audible now, sir?
Yeah, very much.
Yes. So our patient was evaluated for other systems also, sir. LFT, RFT, chest X-rays, 2D echoes were all normal, sir. There was no other evidence of infarction in any other system. Ultrasound, abdomen, everything was done, sir. However, later he developed sepsis. That was urine cultures, and our ET cultures grew Acinetobacter and Klebsiella, and that is how we succumbed finally.
In fact, the body was recovering initially.
Yes.
In your case, whether it was related to autonomic dysfunction or vasoconstriction, what could be the thing like hemorrhagic infarct in the cerebellum? What we see in press-like things, whether that is the type of mechanism of our thing, whether the blood pressure variations were there in the initial 24 hours?
No, sir. Initial 24 hours his BP was stable. It was around 150/80, 140/80. Throughout till the procedure was done. Post procedure also it was stable, sir. Only once he developed the sepsis did he develop his hypotension.
When we reviewed the literature, we saw that IgE level correlates with the disease activity. So in this patient had very high IgE level, which is correlating with the neurological and other complications because of the bee sting.
Very interesting.
So that's good. It's no, but still, what still I have been left with the confusion is whether multi-system infarcts are known with bee stings or selectively they have got affection only for CNS infarctions.
Sir, as it was told that one of these, they are more prone for, this apomorphine, sir. They have increased the affinity towards the cerebellum and the mesencephalon. Apomorphine, one of the neurotransmitters in the toxin.
And your question was why one side was involved. Most of the case reports are showing unilateral involvement, sir, not bilateral.
Yeah, that's quite surprising. It is. So I think I thank the presenters and the moderators for presenting really an interesting case and ultimately revealing the secret of this stroke. So it's quite interesting. Now I thank on behalf of Karnataka Neuroscience Academy, the Mangalore team for presenting these cases and making the session interesting. Now I hand over it to Dr. Guru Prasad sir to tell something about our further plans.
Thanks, Dr. Shivanand and Dr. Raghavendra, to accepting the thing and then presenting very interesting cases.
Thank you, sir. Thank you so much, sir. Thank you.
Really interesting cases, and I think so. We hope to continue the webinars for next few months. The team from Shimoga will be presenting next month in October. At this juncture, I want to take this opportunity to because October 29th is World Stroke Day. We are planning some activities related to stroke awareness. I would like to request Dr. Shivaramakrishna to just speak about the activities. Sir, you are there?
Yeah, I'm here.
Yeah.
So we plan to have stroke awareness programs all over the state at different places this year. In the form of either walkathon, public awareness programs through the media. I request the team from the Mangalore also to participate and organize activities either on 29th, which happens to be Sunday, or anytime during the month of October, so that stroke awareness program is spread all over the state.
We will be putting up with the activities planned in Bangalore and Shimoga under the aegis of Karnataka Stroke Foundation, KNA, and also Bangalore Neurological Society. We will be putting out the activities being planned in Bangalore and Shimoga, and we will facilitate any cities in Karnataka want to do activities. We'll probably provide the content. Dr. Shunan Sharma is the main person who is planning to do, provide this content, and also we'll put it in our group, KNA members group, and KNA other groups, stroke groups, so that we can facilitate the activities across the state. Thank you all.
Thank you.
Thanks to everyone.
Good night. Yeah, good night. Thank you. Good night.
Good night.
Good night. Good night.